This is my second video on nephrology. Let's start once again with acute kidney injury. A 24-year-old man had a fracture due to trauma to one of his legs. He has no significant past and family history. Urine output 4 days post fracture decreased. His vital signs were as follows: blood pressure was 126 by 80, temperature 36.8, pulse 123 per minute, and respiratory rate 18 per minute. Physical examination revealed tenderness to palpation of lower extremity. Further investigation showed deranged kidney function. Urea by serum creatinine ratio 156 by 8 mg per deciliter, and deranged liver function test with AST by ALT ratio of 5600 by 4880. Prothrombin time international normalized ratio of 1.6 and total bilirubin of 4 mg per deciliter. A detailed microbiological workup was conducted to rule out infectious diseases. His blood and urine culture was sterile. No malarial parasite was seen on PS. An enzyme-linked immune format assay for detection of antibodies to Leptospira, Strep typhus, and dengue were negative. Hepatitis A, B, C, and E virus serology was also negative. His creatinine phosphokinase level was 66,000, and his renal USG was normal. Urine dipstick positive for blood. Urine analysis showed less than 2 RBCs PHF. He received alternate day hemodialysis, but there was no improvement in urine output until 14th day of admission. In the second week, fibroscan, splenic portal access ultrasound, and upper GI endoscopy was done and found to be normal. Then he exhibited improvement in renal and liver functions with a parallel decrease in serum CPK and ALT/AST, and hemodialysis support was discontinued on 26th day. He was discharged then after. On 31st day, he developed quadriplegia, for which he was rushed to emergency department. His EKG at that moment of time is shown below. So this is his EKG. So let's approach the case. Since the patient developed oliguria 4 days post fracture with a normal renal USG, with raised serum creatinine and urea, this is basically suggestive of acute kidney injury. Approach to azotemia is to do renal USG and urine analysis. Urine dipstick is positive for blood, but when urine microscopy is done, RBCs are less than 2 PHF. Urine dipstick measures heme activity. Hence, when urine dipstick gets positive for blood, comes this as 3 differentials. Presence of RBCs in urine. More than 3 RBCs PHF is the criteria for microscopic hematuria. Presence of myoglobin in the urine, as it also has a heme group, and the presence of hemoglobin in the urine, as hemoglobin has a heme group. So the possible clinical situation is intravascular hemolysis in the presence of hemoglobin in the urine, muscle injury, especially rhabdomyolysis in the presence of myoglobin in the urine. Since in our question CPK is elevated, this suggests a muscle injury. Moreover, AST by ALT ratio is more than 1. This suggests muscle injury. Muscle injury in settings of 4 days post fracture is suggestive of compartment syndrome. And the question now arises that why in this patient fibroscan and upper GI endoscopy is done. Now, since the patient is having acute rise of liver enzymes with a raised total bilirubin, this suggests acute liver failure or acute and chronic liver failure, that is decompensation of liver cirrhosis. So we need to rule out whether the patient is having underlying cirrhosis or not, because if it is present, and since our patient has AKI, then a workup for hepatorenal syndrome has to be done. The next slide shows criteria for hepatorenal syndrome. Since our patient doesn't has cirrhosis or any sort of ascites, he doesn't has any sort of hepatorenal syndrome. He is not in the state of shock as well. And since the fibroscan of a patient is normal, there is no cirrhosis. In absence of cirrhosis, hepatorenal syndrome can be diagnosed. And another question is, what is the reason for unexplained liver involvement in this patient? Rarely, in case of rhabdomyolysis, there occurs liver injury due to proteases that are released due to muscle injury. If this is so, then there has to be improvement in liver function when rhabdomyolysis subsides. In our patient, it is given that liver function improved in parallel with a decrease in serum CPK. Okay, so this suggests that liver injury in our patient is due to rhabdomyolysis. What is the reason of the patient to get quadriplegic few days after discharge? If you closely observe the ECG, we cannot appreciate the T waves. Let's go back. We cannot appreciate the T waves. So this is lead 2. These are the QRS complexes. So we cannot observe T waves. This is the lead 3. In this lead, we also cannot appreciate T waves. This suggests flattening of T waves. So T waves have flattened, and this flattening is seen with hypokalemia, which has caused the quadriplegia. What is the cause of quadriplegia in this patient now? Our patient is having AKI due to rhabdomyolysis. Okay, rhabdomyolysis produces ATI. In ATI, there is injury to proximal convoluted tubule, so sodium and other electrolytes can be reabsorbed. This causes increased sodium delivery to DCT, and macula densa senses this increased sodium delivery as an increase in the GFR. So macula densa causes afferent arteriolar constriction. This is known as tubuloglomerular feedback. This produces the initial oliguric phase of ATI. When there is recovery of ATI that occurs 7 to 14 days post oliguric phase, the GFR comes back to normal and the filtrate enters the PCT of nephron. Since GFR has come back to normal but the tubules are still damaged, the PCT is still damaged, the incoming electrolytes, that is sodium, glucose, amino acids and potassium, can't be reabsorbed and are lost in urine. This produces the hypokalemia which has caused the quadriplegia. Thank you.